we had a second talk by our own study group, the WSG, and my colleague gave some insights into the ADAPT chemotherapy trial in luminal breast cancer. And I don't want to dwell on this too long, but I think the one curve he showed where he showed that young patients, pre-menopausal patients, recurrence score up to 25, endocrine responders without chemotherapy had a significantly better outcome than patients who were endocrine non-responders in the same setting and had a dose-dense chemotherapy. So the selection we proposed at San Antonio in the young women with up to 3 involved lymph nodes, combining oncotype under 26 together with endocrine response measured by this 3-week window, I think is sufficient to withhold chemotherapy for about half of the young women. I think that's a major message because that is somewhat better from a patient point of view than our exponder, where they say basically all premenopausal patients need chemo. So this endocrine responsiveness testing is something that we should integrate in order to avoid chemotherapy, in particular in the young women with luminal B breast cancer. So that was my personal highlight. But obviously, from a patient point of view, the OlympiA study was the highlights, was the first talk in the plenary session, and it's practice changing immediately. Luckily, it's a drug that's available, the Olaparib, but we need an approval extension. And for the time being, I think we need to start checking for gBRCA in those patients where we have not previously done that with a high-risk disease, but no family history. And then we need to apply for Olaparib as an off-label therapy with the payers in each individual patient until we have the approval to prescribe this in a regular basis. So this was great data Andrew Tutt presented, and that is definitely practice changing with a hazard ratio under 0.5. So that was certainly the highlight from a patient point of view. And then obviously also interesting, the Gepa-Nuevo data with the durvalumab, which showed an improvement in outcome, even though the addition of this checkpoint inhibitor has not improved PCR by all that much. So I think that is also something that we have to follow. Probably this is not going to be the first registration with immunotherapy in early breast cancer. Most likely this will be pembrolizumab, where the outcome endpoint has been reached, but we still need to see the data.